Welcome everyone joining us here at the HoFH Europe Foundation for this important webinar designed to highlight what's new for the HoFH community, but also bring to attention the issues that patients experience and the unmet needs that they face. The webinar is the second in a series of webinars on this theme, in which we're shining the spotlight on the 4 familial hyperlipidemia conditions that we support, which are FH, HoFH, Lp(a), and FCS, which is short for familial chylomicronemia syndrome. We've got some housekeeping rules, and then I'll introduce myself. So if we could have the slide. So the webinar housekeeping rules is you'll know that this webinar is being recorded, and that the recording will be available on HoFH Europe Foundation's YouTube channel. And please submit any questions that occur to you in during the presentations in the Q&A, and save the chat, please, for other things. This makes it much easier for us to make sure that we pick up all the questions and that we can address them to the panelists at the end. We'll be taking questions at the end of the presentations. My name is Jill Prava, and I'm the Rare Disease Project Manager for HoFH Europe Foundation. I'm a patient with FCS, but my role covers both FCS and HoFH. I've learned a lot about the burden of HoFH since meeting our group of ambassadors, and I've noticed crossover in the unmet needs of patients. So I'm really pleased this evening that we'll have the opportunity to bring these to the spotlight. So let me introduce our fabulous panelists for the evening. Maria Nassif from Lebanon, who's now living in France, and was diagnosed with HoFH when she was 6. Selin, who's from Germany and now living in the United Arab Emirates, who was diagnosed with HoFH when she was 3. And Michelle, whose daughter was diagnosed at the age of 6 and who is now 15, so is a patient with FH herself and is a carer for her child with HoFH. And Michelle lives in the US. So we'll be Albert will be telling us about the latest updates in HoFH, and then we'll meet the panelists and they'll tell you a little bit about their experience, and then we'll have a discussion about their unmet needs, which I'll moderate. Again, it's important that please put your questions in the chat and we can address them at the end of the session. So I'd now like to hand over to Albert, who has some slides for us. Thank you, Albert.
Thank you. I'm a pediatric cardiologist in the Amsterdam UMC, and I want to talk about the clinical characteristics and the treatment in homozygous familial hypercholesterolaemia. In the past 33 years, our center more than 4,000 children visited it with the diagnosis of heterozygous FH or homozygous FH. 41 had homozygous FH. And we do a lot of research to what is an optimal treatment. So these are my disclosures. I'm chair of a steering committee and member of a safety board, and receiving research grants for trials in children with FH or high Lp(a). The child is the product of the parents, as this T-shirt beautifully shows. So if you get familial hypercholesterolaemia, that means I tell to the children that it runs in the family, and hyper is high, cholesterol is fat, and emia is blood. So there is high fat in the blood in your family. And sometimes you get it from one parent in one gene. Sometimes you get it from both parents. If it's from one, it's heterozygous. If it's from both, your LDL cholesterol goes more than double up, quadruple, or even higher. So if you don't do a thing, you will end up with a heart attack at an early age. So you need to give lipid lowering treatment, then you lower your cholesterol and you prevent yourself from getting a heart attack. That's the idea. And here's a graph of a vessel, and they put in some atheromas, and you make slices of it, and you see at the right-hand side that slowly it goes from just some foam stells to fatty streaks, etc., etc. And every doctor thinks in the direction of the arrow, but we should think in the other direction, that if there is some fat in, it should be removed at an early age before it becomes calcified. That's the idea. So in homozygous FH, we start at the moment of diagnosis, sometimes at 5 months old, or if they are diagnosed at the age of 2 or 3, we start at 2 or 3. That's all because, like cigarette pack years, cholesterol is also a matter of pack years. If we reach a certain level at the age of, let's say, 70, and above that age, you increase the risk of heart attack. People with heterozygous FH, if you don't do a thing, reach that already at the age of 35, and homozygous FH much earlier, at the age of 15 or earlier. So we should, as all the doctors should know, because it's not a rare disease, they should look at xanthelasmatas. At the left-hand upper side, you see the xanthelasmatas at the inner side of the eye. You can see an arcus cornealis at 6 o'clock. You can see eruptive xanthomas at the Achilles tendon, so near the foot, and orange-like, and also in the buttock. I normally don't look at the buttock, but when you see it at many sites, you want to know if there are others, and they will disappear the moment the cholesterol goes down. That is really important. 23 specialists from all over the world, we gathered. I was one of the 3 pediatricians in to look at new treatments and clinical guidance. And I only want to focus on 3 topics of one figure. In the past, one says if the LDL cholesterol was higher than 13 or higher than 500 milligrams per deciliter, think of homozygous FH. Nowadays, we think if it's above 10, above 400 milligrams per deciliter, it can be homozygous FH. Of course, both parents will have high cholesterol, or you will have that clinical signs as earlier shown. The second part of this figure is that we have new goals. We want to aim for lower cholesterols even in children and adolescents. In the past, it was 3.5. Now we want to go below 3 in children. And in adults, in the past, it was below 2.5. Now they want to go below 1.8, and in some cases, even below 1.4. That's a challenge. In the past, we only had oral drugs and apheresis. And we do routinely in all the children weekly apheresis, and it leads to a significant reduction of cholesterol and also a reduction of xanthomas in homozygous children, but we are uncertain if it fully protects you from cardiovascular disease. So that needs to be evaluated in the future. But nowadays we have new types of drugs, and I will come to PCSK9 inhibition, lomitapide, angiopoietin-like 3 inhibition, and I will say when it can work or when not, in combination perhaps with lipoprotein apheresis. And it's important that it's not plasma apheresis, and then you remove many more things. It should be lipoprotein or LDL apheresis. Nowadays, we easily see the coronary arteries around the heart, and you can see the inside of the coronary arteries if there are plaques. You are going into a CT scan and you're already out without any, hardly any radiation anymore. In the past, it were 30 X-rays of the thorax. Nowadays, it's 1 X-ray. And there was a breakthrough in adolescence. We saw that fat is already visible at young age, shown by these CTCA, and can come out of the vessel wall. Here you see, with a new drug, evinacumab in this case, cholesterol in a 12-year-old girl more than was decimated from 130 milligrams to 60 milligrams. So that's an enormous drop. And in the 16-year-old girl, it was half the former height of the cholesterol, from 120 to 60. And we repeated CTCA every 1.5 years. So 1.5 years later, and at the top you see the 12 and 16-year-old, they had in yellow a plaque in the coronary artery. And 1.5 years later, after the intensive treatment, the plaque was gone. So if it's not calcified, these plaques were not calcified, it can be removed from the vessel wall. Even in homozygous age, plaques can disappear as long as it is not calcified. If you have some rest activity of LDL receptors, I tell the young children that they have fishing rods in their liver that get the cholesterol out of their blood. You can have benefit of PCSK9 inhibition. These are available: Avery once per 2 to 4 weeks, alirocumab once per 2 to 4 weeks, and inclisiran once per 6 months. And yet in adults, and evolocumab from the age of 10 in children already. But you should have at least LDL receptors. Here is how it works in the liver cell. At the left-hand side, you see where a receptor is assembled. At the right-hand side, you see the bloodstream where the cholesterol bulbs are in. So here is a receptor assembled and then transported. Golgi complexes in every cell brings a receptor to the wall, to the surface, and then it grabs an LDL bulb, bring it into the garage, and bring it finally into the cell, and the cholesterol is important for activity. But the receptor itself is recycled. Nature is saving. It costs 45 minutes to make it and 10 minutes to recycle. If you have high PCSK9 in your blood, it sticks to the receptor and the receptor can't be recycled. So nowadays we have anti-PCSK9, and anti-PCSK9 removes the PCSK9 from the blood, and you can recycle your receptors. But you need, of course, receptors. And in homozygosity, sometimes there are not that many receptors. So then other drugs are available. Nowadays, lomitapide is approved for adults. It's an expensive drug, but it's approved by the FDA and the EMA for adults. And trials are done in children from the age of 5 years old. It acts independent of LDL receptors. The benefit, it's a tablet, daily tablet. The disadvantage is you need to be put on a very strict diet. I thought of a benefit and a disadvantage. Evinacumab also acts independently of the LDL receptor, is approved for adolescents from the age of 12 and adults, and also a trial from 5 till 12 is done and will be published, I think, this week by FDA and EMA. The benefit, you don't need a very strict diet, but the disadvantage is it's once per 4 weeks via an infusion. But what we saw, and we will publish this week, in 5 till 11-year-olds, it drops your cholesterol with more than 48%. The take-home message is it's all about pack years. Fat can come out of the vessel wall, calcium can't. So the younger, the better. Thank you. I hand it over to Jill.
I said, thank you, Albert. There's a lot of very positive information that you shared there, which will hopefully change the landscape for HoFH patients. However, it does have to be said that treatments, even if it's on the horizon, won't necessarily get to all the patients. And for the moment, at least, many patients won't actually have been diagnosed, is another issue. So I'll move on to the unmet needs that we're talking about. And we were going to turn to first. So there are treatments in the future. This is what I was saying. Treatments in the future, but it will be difficult for patients to necessarily access them. And so what we need to learn about is really what the experience of patients is now, with the future in mind. So Maria, I'd like to turn to you. Do you want to share a little bit about your experience with HoFH and what you've learned from it, please?
Yes, of course. Thank you, Jill, for the introduction. So originally, I'm Lebanese. I have been diagnosed with HoFH since 6 years old. I started directly with the apheresis LDL, with the sequestration. It's like statin for children. And later on, starting age 16, 17, I started to do the echodoppler, echocardiography to see the arteries of the neck of the heart, and start with the statin, with the aspirin. And 24 years old, despite all of this, following up from my doctor and the treatments and the medication, I ended up having the first or the only open heart surgery, because I got atherosclerosis in my heart arteries by 90%, which is, I think, really, really hard for a 24 years old person. And at this point, I went to France because I know that the treatment there is more advanced and more efficient. So at 2018, at 25 years old, I got to France. I started with my treatment, apheresis treatment, more statin, and the level of LDL cholesterol has been, how to say it, it was downgraded from 600 milligrams per deciliter to 100 milligram per deciliter from the first treatment. Comparing to in Lebanon, every treatment that I did since 6 years old till 24 years old, I only have a result from 600 to 400 milligram per deciliter, which is not enough for a homozygous person. And here is the importance to say that doing treatment isn't enough. We should look after the efficiency, look after the results. If they are not well, we should try to focus and search for other treatments, whether it was the apheresis by itself or the medications. And 2 years later in France, I was put on a newfound medicine that my doctor has prescribed, and the results were even more efficient. I got the LDL cholesterol get down from 200 to 35 to 50 milligram per deciliter from one session. So I always say that I have a privilege being in France. I came here for my studies, and then I find out of this immense efficiency of the treatment, the care, the proficiency of my doctors. And I think, as Dr. Wiegman said, that the earlier the better. So I think we should really directly tackle the problem of patients from beginning, from the time they are diagnosed with the HoFH. And I still have the atherosclerosis because they got, I think, calcified. I have in my heart arteries, in my neck arteries, and my my legs, and it affects my daily life because it tires the heart. I'm not gonna hide this. It makes me get tired really easily. I can function well at work, or I can do sports, I can do high activities. And as 30 years old, it affects, and I feel sometimes I can't really act as a 30 years old. So I think it's really important to start with the efficient treatment very early.
Thank you, Maria. I wonder if, because you shared with us some photographs of the difference of the treatment
Yes,
that you experienced. I wonder if you could just talk us through these.
of course. So these are photos that I've taken really randomly, and then I have, at some point, I remember that I took photos in Lebanon and in France. So we have lots of photos from 2017, 2018. These photos are taken, I was still in Lebanon under the treatment in Lebanon. So we can see the xanthomas that I have, the immense amount of xanthoma that I have on my hand. Regarding that, I was doing treatments, the apheresis, for like 20 years, and I still have the xanthomas on my hands. And then we see photos from 2020 and 23. And these are the results of only 2 to 3, 4 years of LDL treatment, the apheresis LDL treatment in France. That's where I have to put more accent on how much the efficiency of the treatment is important for a patient.
And what you're saying is that actually in different clinics in different parts of the world, the treatment is delivered differently, and
Exactly.
that needs to be kind of standardized really in terms of what's best for the patients.
Exactly.
Thank
Although
you.
I was doing the apheresis on the same machine, but I don't know if it's mainly about what the medication is put into the apheresis that should be more standardized and shared everywhere in the world.
Thank you. Lynn, moving over to you, I wonder if you could introduce yourself and if you would tell us a little bit about your experience. And I wonder if we would share your video first, please. We have a little video of Selin.
Okay, if you like, we can show the video first.
So you actually, Spella, can we stop this? Can you just say what this is, Selin? Sorry.
This is me in the middle, in the green, and my two sisters and my mom. This was actually right after we were diagnosed with HoFH. And my mom is speaking about our xanthelasma and how she found out. It was a very long process, actually, with my dad together, how they found out that we have HoFH. And it was a horrible experience for both of them because they didn't know what that is. And they went to so many doctors, asked so many people, and they really didn't give up. And in the end, they found out that this is HoFH and this is xanthelasma. And they said that our life expectation would be maximum 12 years. By the way, I'm 36 now. And this is the video how Professor Dr. Steinhagen-Thiessen explains what we have and how she asked my mom questions about how we found out. So the xanthelasma were on the joints mainly, on the knees, on the elbows, and on different parts of the body also. It was a very difficult experience as a child to go through that. Here you can see my sister's knees. It was the most extreme case with my middle sister. So we are 4 children, and at that time we were 3 girls. After 11 years, my brother was born, but luckily he didn't have a HoFH. So yeah, on one hand, that's very good. On the other hand, my parents got this diagnosed that 3 of their kids have it and they might not live very long. So yeah, it was a very difficult time. And for me as a kid, I remember when I was going to birthday parties and I could not have the cake or chocolate or anything which could elevate my cholesterol levels. And I didn't really understand, but I was really lucky, first of all, to be in Germany because I have Syrian Turkish roots. And second, my parents were really powerful to go through all of that and not to give up and to try anything they could try, because they didn't have any knowledge and they were trying to gain knowledge and to ask and to read and to do everything. So yeah, I was really lucky. And in that time, it was 1990 when I was 3 years old. It was also not so diagnosed even in Europe and in Germany. So we were really lucky to have met also Professor Dr. Steinhagen-Thiessen. Yeah, now I am 36 years old, as I mentioned, and I'm living in the UAE, and I have difficulties by getting the treatment because in this country we don't have the treatment. We don't have the apheresis here. And I'm traveling almost every 2 weeks to Germany to get my apheresis done. This happened last year in October. It was exactly 1 year ago that I said, okay, I really have to travel every 2 weeks because I have the discomfort in my chest, and I felt that something is wrong. And I went to the doctor, and the doctor didn't take it serious. And I insisted actually that we are doing a stress test to just check, because I felt that something is wrong with me. And yeah, the doctor underestimated the case a little bit. But then we did the stress test, and then a day later, they found out that I have 2 blockages. One was like in the heart, one was 80% and one was 65%. And they immediately put 2 stents in the heart, and now I take it even more serious than before when I was living here in the UAE. So only the medication didn't work with me. And I saw that the apheresis was the most effective treatment for me. First of all, because there are no big side effects. And second, because I saw the cholesterol really dropping immediately, same day, more than 70–80%. And when you take any kind of medication, it takes time, and also you have side effects. So that's why I'm really, for the apheresis. And I wanted to maybe add to Maria. I think from my experience over so many years, I started with apheresis when I was 10 years old. And I think that maybe her doctors in Lebanon didn't use the right filters. Maybe the amount they didn't use right, or the amount of blood they filtered, like less amount of blood. So maybe this is the reason why it was not so effective. I don't know, but there is definitely a lack of knowledge and information, and so many doctors I met in my whole life didn't even know about HoFH and didn't even know that a young person or a child could have that. So this is something very important that we should raise awareness, and we should definitely talk to any cardiologist or lipidologist we know, or nephrologist, and to talk about that, to tell them, yes, we can have it. And if someone is coming to you and telling you, I don't feel good, I have discomfort in my chest, and I have dizziness, and I feel something is wrong, then you should take it serious as a doctor and not say, oh, you're young. Yeah, I'm young, but there are so many things I can have, even if I am young.
So Thank you, Selin. It sounds like we'll come back, I think, actually, in a discussion about the impact that the travel has on you and who funds that. But it sounds like that you've had to very much advocate for yourself and very much kind of push for what you know you need. And that's an extra burden, really, to have to do that. Michelle, moving to you, you're a carer, but you're also a patient yourself. I wonder if you would just say a little bit about your daughter's journey, and also we could just show the slide of the group that you founded on the back of, or as a result of your experience with your daughter. So do you want to just talk to this a bit and just say how this occurred, what you did?
Sure. Thank you, Jill, for having me today. Thank you, HoFH Europe. I'm happy to be able to share a little bit of our story with you today. On the screen currently, we have different social media outlets. We have a website that needs a lot of work, but a Facebook page, an Instagram page, we tweet at times. So we try and get the word out there. This came about because about 9 years ago, our daughter, Avery, who was 6 at the time, was diagnosed with HoFH. And to get information out to our friends and family, I started typing messages on Facebook. And then I was like, I should really put all of this in one place. So I created a Facebook page for Avery, and we called it Avery's Fight. And after the Facebook page, I said, we should be on Instagram too, and let me do some blog posts about what I was feeling and what we were all going through. And so those ended up on the website, and that's kind of how that all kind of transpired.
Michelle, what was your experience? Why Avery's Fight? What happened to Avery? What was Avery's story?
Well, we were very lucky. Avery showed no outward signs of having HoFH. So she was diagnosed, we like to say a little by accident. But within the first year, she was started on medications, and then a port was put in her chest to facilitate doing apheresis treatments. And right before her 7th birthday, she started doing apheresis. Now, these treatments were a little difficult for a couple of reasons. First of all, for Avery, to facilitate the apheresis and the amount of blood flow that needs to go through the machine, the needles they use are very big needles. They're 16 gauge needles, I believe, is what is used on her. And so seeing 2 16 gauge needles stuck in your chest every day when you're 6 years old was quite traumatizing. There were times that, she'd be screaming and crying, and we're trying to hold her down, and we're crying, and it was just a mess. There was a lot of trauma in the beginning. And we were going originally every 2 weeks, and then for many years, every week. The hospital that was the closest that had apheresis for her, and where her doctor was located is 3 hours from us. So we would leave early in the morning, drive 3 hours to the hospital, do everything we had to do pre-apheresis, get her hooked up. And the apheresis at that time was taking around 5 hours. And then whatever had to be done post-apheresis, blood work, that sort of thing. And then we drive 12 hours back home. So they were like 12 hours of very long, very exhausting days for all of us. But on top of that, when Avery was diagnosed, the hospital which she was seen at for apheresis and to see her doctor and any appointments, any tests that needed to be done. That hospital had no agreement with our health insurance company. So every time we had to have any appointment or we wanted to go to the hospital for any reason, I had to spend, I don't know how, like hours and hours on the phone with the health insurance company, trying to explain to them that no, she's not gotten better since I talked to you last week. This is something that's lifelong, and it's, you know, it's a chronic illness that she is going to have forever. And it took a very long time for them to understand that. And unfortunately, I'd have to talk to a different person every time I called in and start from scratch. So that was difficult. So I would say those are probably the three things that made apheresis very difficult to start out with. Things have gotten much better since then. Because of a new treatment, we're able to space out Avery's apheresis treatments to about once a month now, which is a godsend. It's such a change in our lives. Yeah, I would say regarding apheresis, those were the three biggest struggles that we had.
Thank you, Michelle. What really struck me as you were talking about that was the trauma that you described for Avery, but also I imagine for you as the carer, and I wonder how much support was offered for this trauma that you were both experiencing, and how much. And this, I guess, is a general question for everybody. How much support do you have regarding the mental well-being effects that you have through your treatments and your... So Michelle, did you want to speak to that first?
Yeah, I would love to. Early on in her treatments, in her early years of the disease, we could tell that it was something that obviously affected her greatly. And so I got her involved with a mental health therapist and figured maybe they would hit it off and they could start talking about things that might be not so significant right now, but then she would have this person to speak to as the years went on, and hopefully they had a relationship. It didn't exactly work out that way, but that was the goal. And since then, on and off, I've gotten her either into therapy or gotten her medication. She has a lot of anxiety around her treatments and her condition. And the treatment for anxiety seems to help her a lot. And myself, Avery had in 2020 2 open heart surgeries and a heart attack, and then another open heart surgery in July of 2022 with COVID there in the middle. And all of that was a lot to handle for her, for our whole family. Definitely, it was hard for me. So I am happy to say I see a therapist and we talk through things. And I think they have a term for being in the CICU, like PTSD for the CICU. Like that's a real thing. Being in the hospital for a month it takes a lot out of you. Yeah.
Thank you. How about Maria and Selin? Do you have anything you'd like to add to that about what support you've been offered?
Yeah, definitely. It took me a very long time to acknowledge or to just admit to myself, okay, you have something which is affecting your life so much. Because when you speak to people outside, they don't understand, they don't know, and they're looking at you, and you put your makeup on and you put your high heels on and they think you're good. but what's going on inside of you and the whole struggle, what I'm going through every week since I'm 10 years old, like not only the apheresis, this is sometimes some body parts are hurting so much, or I have on my Achilles tendon this xanthelasma still, and it's really tiring for me, and I cannot function normal, I cannot work normal. And now also additionally that I have to travel every 2 weeks on my own expenses, and nobody is there to help in this. So I feel like I'm running the whole time, and I don't have time to rest because I'm working for my treatment. My whole life is around this only. So mental health, I think I felt honestly nobody really cares. You yourself have to go and seek help or go to a therapist, but also that you tell yourself, okay, don't act as if you don't have anything and just act like you're a normal human. Yeah, you are on one hand. On the other hand, you also have to deal with it in a way. So yeah, this is a very important part, especially when you face this as a child. You don't know what's going on, and why am I different, and why am I always going to the hospital and I cannot just go and play like the other kids. So I'm really sorry to hear the story of Michelle's daughter, and I'm also very proud of all our patients we have, and every single person who is going through this and who's so strong and still fighting. Thank you, everyone, for being here right now.
Thank you, Selin. Maria, did you have anything you wanted to add about what support you've been given for your psychological well-being?
I haven't
Okay, no, that's
got
fine.
any psychological help. I was only kind of on my own, saying, okay, I am sick, I have to deal with it. I've always said that everyone has something to deal with it, so I was going this way. And I want to talk about something that Michelle talked about, is the anxiety that we got because of this disease, because actually anxiety and heart disease are practically the same. We got dizziness, we got the heart beating, the fast heart beating. Sometimes we think it's anxiety, sometimes it's heart disease. We don't know what's happening in our body. And as Selin said too, that no one knows the pain that you are living, that we have. We feel pain every day since we get up. I feel tired every day, and it's hard to tell people because it doesn't show. And every time I tell people that I have this, I have that, I do treatments, I have heart issues, they say, yeah, but you look fine, you have your life. Yes, I do have a life, but there is an effort done between all of this. And so I think here we should talk about having more awareness, especially for kids, because they have the xanthomas on their hands, they have needles in their hands at 6 years old, and no one knows about it, and it's painful and it's not easy, and they don't understand it either, and the parents aren't really the good people to speak to them about this because they're not professional, and the doctors don't care actually. That's why I think it's good to tell kids what they are going through, what they have, in a kid's way, and then make it a disease more known internationally, because first there is how to say, not misdiagnosed, but lots of people aren't diagnosed, and something that we talk about here in France, and lots of people don't know what it's about.
So there's, sorry, Selin, go ahead.
I wanted to add a small story about my childhood when I was bullied, or my sisters and me, we were bullied because we had xanthelasma on our knees and we were on vacation, and we just wanted to jump into the pool and have fun like normal kids. And my parents were attacked by other parents, why we jump into the pool, and this is ugly, and this is like, we're not allowed to jump into the pool, and they had to fight against that attack, kind of, why we want to jump into the pool, and people don't even ask, or they don't even have this empathy. So imagine going through this and nobody's going to help you. The parents also themselves, they already carry so much with them, and then to be attacked because of these kind of things, that's really horrible. So I think definitely we should raise our voices very loud to support parents and kids.
Thank you, Selin. What I've heard a lot about from what you're all saying here is the need for information and an awareness, and for clear information that's kind of suitable for different age groups, and to have doctors who understand exactly what they're dealing with. And I wonder if anyone wanted to share any stories of issues that they've experienced in terms of what treatments they've been given. If you didn't, you don't. Okay, so
I have a lot of stories, actually.
Right.
I don't want to put too much up right now on one hand. On the other hand, I want to share these stories so people know, and people can be careful about their own steps, or open their eyes a little bit more. So what was the most difficult thing for me with the doctors, for example, it was that the lack of information. So they are coming to you, they're offering you this new medicine, there's something new. Okay, we want to try everything, but they are not telling you if this medicine is specifically for you or not. They're just saying, yeah, there was a trial and it worked. Sorry, this is my dog in the background, by the way. There's a trial and it worked with so and so many people, but nobody is telling you that this could be maybe not good for your gene mutation. So they just give you something and you try it because you are desperate and you want to try anything you can. And then later on, they're telling you, oh no, this is not good for you. Yeah, thank you. I was fighting to get that medicine for so long, and to pay for it, or to bring it from a different country, or in some countries they don't even have this. And then I put these chemicals inside my body and I have the side effects, and then you are telling me that this is not for you. Like, how come?
Yeah. So it's education is also for the particular doctors, and to and I have to say that that's not for all doctors everywhere.
No, of course. Amazing, yeah, amazing doctor.
Yeah. But some, just the yes, in no way is that's the case. But I think there's what it speaks to is the kind of lack of awareness really across everywhere, and that the need for information to be kind of created and shared. I'm aware that we need to take some time to ask questions. So I wonder if anyone has any last thing they want to say about unmet needs, or if we're happy to move on to questions now.
I want to add one thing importantly, especially women have difficulties to bring on stage that they have heart problems, especially young women. And many doctors think young women won't be ill. So there is an extra need for them to shout out loud what's needed. Other thing is, there are treatment can be tailor-made. As I started, PCSK9 inhibitors are doing well if you have rest activity. Otherwise, they won't work. So you should be prevented for certain types of drugs that won't work. So we should educate all the doctors as well. What will work, what won't work. The good thing for you is that I spoke about uncalcified plaques. You all have uncalcified plaques, and if the moment they are removed, they can't be calcified anymore. And you, of course, all the children in my outpatient ward have also some calcifications, but the parts where it's not calcified, that can be removed by lowering your cholesterol. And you're a perfect example because you are in your 20s and 30s, and the daughter of Michelle in her teens. So there are, in that way, decades in the future. And here I stop.
Thank you. Let's go to the questions in the Q&A. If anyone has posted a question in the chats, please could you transfer it to the Q&A so I don't, because there's quite a lot of comments there. Okay. So this is a question for Albert. It's from Javier Gomez. Evinacumab is licensed for homozygous FH only, and the price is prohibitive, which I think limits its generalized use. Do you know if there's a good reason for evinacumab not being effective in heterozygous patients? Thank you.
In heterozygous patients, there are other types of drugs that will work, and they are cheaper. This very expensive drug should be preserved for those who are in great need. Homozygous FH, they lack LDL receptors, and therefore you need drugs that don't work via the LDL receptor.
If I could just add here, actually, that we that if a medicine is extremely expensive and it's been licensed by the EMA, so it can be used, that doesn't then translate into it being available in home countries and paid for by the reimbursement agencies. And we were discussing earlier just the importance at this stage of the patient voice to be involved in that process, and patient advocacy and raising awareness really amongst physicians to back the drug to be accepted in a home country. So just to do a shout out really about the importance of patient voices in what you three have been doing tonight is really important, and with support from physicians as well. So Elsie is asking, does the efficiency vary from, does the apheresis efficiency vary from country to country, and how are these monitored? I guess that's to Albert as well, actually.
Yeah, Selin can start first because she has experience in both countries.
Yeah, actually in more countries. I was doing the treatment in Turkey, in Oman, in Germany, so 3 countries. And I have seen that all doctors are really invested and they're amazing and they're trying their best, but sometimes it's, again, the lack of knowledge about the filters, and also about some people, for example, they can have an allergic reaction, like me. I always have an allergic reaction and I cannot breathe so well when I do the treatment. So in the beginning, it was difficult because we didn't know what that is and how to handle it. So we just turn off the machine, let me breathe, open the window and do some breathing exercises, and then we restart it again. But sometimes it's just people don't know that, and then you are going through so much in this session and it's really traumatizing, and then after that you don't want to go for 2-3 weeks to the session anymore. So this is a very fine and important thing, that we see each patient different, and we listen to what they are really feeling. It's not that they are just saying it like that. We all have this, and we are coming to the treatment and we are forcing ourselves because we have to. And then we just want people to listen to what we really have to say and how we really feel. So the difference, I think, is the knowledge and the experience And as I said earlier, also the amount of blood for this specific person with this kg should be different for a child and should also be different for an adult. And then also for people who already had heart surgeries or stents, then the treatment should be a little bit slower. So there are big differences, but I think it should be standardized in a way that everyone knows, okay, for children, we have this filter. For adults, we have a bigger filter. And when I was in touch with the companies who are providing these machines and the filters, they also explained to me that different filters are for different people. So it's very simple, but we just need to, raise awareness and also educate ourselves and doctors also.
So that's very much about putting the patients at the center of the experience that they're having, and listening to the patients. Thank you, Selin. I'm painfully aware that we're really running out of time. So if I could just ask you, there's a couple more questions for you, Albert. Are there noted side effects for apheresis? That's from Elsie.
Yes, one of the side effects is well described by Selin, that you can develop bradycardia and then you get short of breath, and you should slow down the process and use other types of filters. So it's a matter of that I, as a pediatric cardiologist, don't do the apheresis. I refer them to the pediatric nephrologist. They know how to work with apheresis. That's a specialty. Don't do it yourself. Refer to those who have the best experience.
Right, thank you. Do you have data on the regression of LAT and positive remodulation after weekly apheresis? Albert, I guess this is for you again.
Yes, the explanation is that apheresis stops the process, but the new types of drugs remove, on top of even of calcification, there is new plaque, removes it because it lowers the cholesterol even more. And that remodels the vessels. The good thing is in your body, there is a lot of sort of drugs in yourself that help to make it normal again, as normal as possible. That's the extra message with it, because you all three showed how intensive you are treated and where you are still dealing with. But that's the promising thing for the future.
Brilliant. For those questions that we haven't addressed, we will do those post the webinar, and then they will be included in the report afterwards. So because I do really need to bring this to a close, but what I just wanted to sort of summarize a little bit, that the kind of unmet needs that have really come out across this meeting this evening for me is a need for access to treatments that's kind of available. It's the need for early diagnosis, really, to get treatment to patients as soon as possible, that the information is very clear and it's understandable by everybody. That's both physicians who are treating and also for the patients who are being treated. And that's it's quite important, or it's very important, really, that patients have to do a lot of advocacy for themselves, and that shouldn't have to be done. That they shouldn't need to do that, because you're already dealing with what is quite a burden. So it's important that there's consistency, I guess, in how people are treated, and that the patient personal experience is put first, so that each patient is treated as an individual, not as an HoFH patient. So a lot, and mental health support is lastly, I would say, the last thing. So so thank you everybody for did anyone so thank you everyone for attending this evening, and I just want to kind of close really by saying absolutely brilliant to all the panelists, and thank you for Michelle, Marie and Selin for sharing your stories, which are very powerful and is very helpful for other people who are not aware of the impact of HoFH. And thank you very much to Albert. So I just wanted to tell you of an exciting new initiative that we have in terms of raising awareness for HoFH, which is we're going to be launching the very first HoFH Awareness Day on May the 4th in 2024. And we have a lot of global support for that from lots of global organizations. So it would be really good if everybody could join with us to help to raise awareness, because that seems to me to be the first step, that people need to know what the impact is and what the condition is and how to treat it. So finally, we've got 2 more webinars in this series. These are, as I said earlier, next Thursday will be the underdiagnosis of LPLA, how patients and healthcare professionals can work together for change. That's on the 26th of October, which is next week. And on the 2nd of November, it will be focusing on FCS, and we'll look again at the latest updates in the area of FCS and the patient perspectives on unmet needs. The 12th of October webinar is now available online. Thank you very much for this. We'll be posting the recording of this webinar, and we'll answer the questions that we were unable to get round to. So thank you again, panelists, and thank you everybody for joining this webinar today. I hope you found it useful, and we'll say goodbye. So thank you very much.
Thank you.